Hello and welcome to the Edutalk series hosted by Biotone EduPartner Program, and massage industry experts. With the growing interest and popularity of the Edutalk series, Biotone continues to support virtual learning and building massage community by connecting you with industry experts who share their knowledge and expertise on topics not only for class discussion, but career success. Today's expert is Mariann Sisco, a practicing physical therapist with 40 plus years experience. She's a practice owner, researcher, certified international educator with Upledger Institute and Barral Institute. Plus, she's a certified CranioSacral Therapy Mentor and examiner for CranioSacral Therapy Techniques Certification Program. She's a contributing author to Methodologies for Effectively Assessing Complementary and Alternative Medicine, and participated in Concussion Intensives for pro football players and post-traumatic stress intensives for veterans. Let's listen and learn as Mariann explores how craniosacral therapy can relieve persistent concussion symptoms such as headaches, dizziness, anxiety, difficulty concentrating, and sleep issues. Concussions are a whole body event, and craniosacral therapy being a whole body therapy. Understand how craniosacral therapy helps post-concussion clients find relief through releasing restrictions in the cranial bones, the attaching intracranial membrane, and the brain, as well as associated body injuries. Welcome, Mariann. Thank you so much for being here tonight and sharing your knowledge with us. And I know you have a lot to get to, so I'm going to turn the screen over to you. And I will see you on the other side. And to our audience, thank you for joining us. Please be sure you are muted and your video is off. And during Mariann's presentation, please chat questions or comments, which will be answered at the end. Thank you. And with that, there you go, Mariann.
Okay, well, thank you, Donnell, for that lovely introduction. Hello, everyone, and thank you so much for attending this presentation. We've got a lot to cover in a short time, so we'll go ahead and get to it. I'm gonna share my screen. And we will start the slideshow. And first off, I do want to thank the Biotone company for inviting me to present on concussion. It is something that a lot of people suffer from. And so we are going to be speaking and sharing about Upledger CranioSacral Therapy and concussion. And this is our outline for this short period of time. We're going to go over the anatomy of the craniosacral system. We're going to talk about the fascia and the craniosacral system. And then we're going to put together concussion, fascia, and craniosacral therapy. And we're going to talk about the biomechanical considerations of concussion, the causes of concussion, and how craniosacral therapy helps. So let's get to it. We'll start first with our anatomy. We're going to look here at the attachment of the dura mater, which is a significant part of craniosacral therapy. And what you are seeing in this illustration is someone who is lying supine. And you see kind of a funny looking structure here in the area of the head. This is the intracranial membrane, and it attaches at the foramen magnum in the occiput and continues down as the dural tube and it enters the sacral canal and attaches at the second sacral segment, and then it reemerges out of that sacral canal here and blends with the periosteum of the coccyx. Okay, this is showing you an illustration of the intracranial membrane. We have here a vertical part of that membrane called the falx cerebri, and it separates the something happened to the sound. Are we good?
You have a slight echo, but feel free to continue.
Well,
It's gone now.
is it? All right, good. All right. So we've got the falx cerebri, which is a vertical membrane, and then we have a horizontal membrane called the tentorium, and hidden below here is another smaller membrane. And this is a schematic of that membrane that all of our students receive in Cranial 1 classes. And again, you see this vertical membrane here, the falx cerebri, a horizontal membrane. Underneath is a smaller membrane. And then there is an attachment at the opening in the occiput called the foramen magnum, where our spinal cord emerges. And what happens is that this membrane is inside the skull, and it separates the brain into different compartments, and the membrane attaches to the bones, and we use the bones as a handle to mobilize restrictions in this intracranial membrane. And the intracranial membrane, this is a dissection. This would be what it would look like in situation where here you see the undersurface of that vertical membrane. Here's where it divides into the left and the right tentorium. And here in the picture, you see the optic nerves, the optic chiasm, and that brown spot right here is the pituitary gland. Okay, so then also is the intracranial membrane is made up of dura mater, which is Latin for tough mother, and the inside the skull is lined with this dura mater, and part of that folds in on itself and creates the intracranial membrane. And so this is showing you the part that is basically lining the cranium. Here's our foramen magnum attachment, and there's attachments at C2 and C3, and then this goes down around the spinal cord, and then it narrows down and enters into the sacral canal, exits out, and blends with the periosteum of the coccyx. And again, there's the intracranial membrane that is also made up of dura mater. And the most important piece here for everyone is that the dura mater is the fascia of the nervous system. It is made up of the same type of tissue. It is just oriented differently and has a bit of a different function to a certain extent. Okay, and then here again is our intracranial membrane, also made up of dura mater, fascia of the nervous system. And there is our attachment there. Okay, so that part that is lining the cranium is, if we've taken the top off, and the top is sitting over here, and all of these nooks and crannies is lined with dura mater. And the top, if we were able to turn it on the other side, is also lined with dura mater, which is creating this part of this picture. So both illustrations are important because we've got the lining inside the cranium, and we have the formation of the dura mater forming this intracranial membrane, separating the brain into compartments. Now, the dura mater is one of the meningeal layers, And I'm going to start by sharing the meningeal layers around the spinal cord. They are also around the brain, but the spinal cord is circular and just makes a little bit more symmetrical picture to understand what we are seeing. So here in green, we have the dura mater, which is the outermost layer. That is the fascia there of the nervous system. Then the next layer in is the arachnoid layer. And arachnoid means web-like, and it's referring to spider webs because of these little structures inside this space called the subarachnoid space. These structures are called trabeculae. And the cerebral spinal fluid is circulating in this subarachnoid space. Then finally, the innermost layer here is the pia mater, which is Latin for soft mother. And the pia mater is like shrink wrap for the brain. And so here we have the central nervous system inside. This is the spinal cord, which is part of the central nervous system. Okay, and if we were going to look at this less schematically, we will see in this picture, this is an enlargement of the segment of the spinal cord. And what you're seeing here in yellow is the dura mater. Okay, and you see that it travels a short distance out with the spinal nerve. This would be the spinal nerve. And so this is all the dural tube, the dura mater here. Then this next layer here is the arachnoid, and you see the trabeculae there. And this entire space would be the subarachnoid space. Then here, outlined in blue, because it was a little hard to see the shading on the original picture, is the pia mater. So this is like shrink wrap here for the spinal cord. Now, let's look at the brain. The same thing is we've got here our cranial bone, and then you see the dura mater here that is lining the inside of the cranial bone. Then you see the two-cell layer of the arachnoid layer. Then this would all be the subarachnoid space. This is where the cerebral spinal fluid is circulating. And then right here, you see the pia mater, a single cell layer that is like shrink wrap around the cortex of the brain. Okay, next we're going to talk about the fascia. And there, I'm pretty confident that many of you are very familiar with the fascia, so this may be a bit of a review, but I would like to put it in the context of concussion, which we will be doing shortly. The main thing that I would like for you to notice is that most of the body's fascia is oriented longitudinally. Okay, kind of like a freeway system here. And then there are 5 areas where the fascia is oriented horizontally, okay, which you see here by the red lines. And we call these the transverse planes of fascia. They are also sometimes referred to as the transverse diaphragms. And they are here, we have the pelvic diaphragm, then we have our respiratory diaphragm, then another transverse plane of fascia is the thoracic inlet. Here would be the hyoid, and then the broken line in the back is referring to the occipital cranial base. This you may know as the suboccipital musculature. Now, why is important? Well, a number of reasons, but let me give you an example of what can happen. Is that, say someone falls on their knee to the ground. There is a force that they encounter, And when that occurs, you can see, because of this longitudinal orientation, that that force is going to travel up pretty fast, because this is like a expressway. But then once it hits this transverse plane of fascia, because it's oriented in a different direction, it slows down that force as it's entering the body. And it starts to absorb some of that traumatic force. And then it is back on the freeway again, and it is traveling still faster, but not faster, but still rapidly. And it gets dampened again by this transverse plane of fascia. And then this continues on up, and it can continue all the way up into the head. And something that's actually not well known and well discussed in the literature is that someone can have what is referred to as a sacral concussion. What that means is, and this may have happened to you, where you've landed on your buttocks, and if we land hard enough and on a hard enough surface on our buttocks, that force of that traumatic force can travel up very rapidly up directly into the brain, because of the cerebral spinal fluid around the spinal cord and the brain. That the laws of fluid dynamics, they travel very, very fast through the fluid system. And so one can land on their buttocks and end up with their brain having being shaken up in the brain or in the skull, and create a concussion that originated from their sacrum. Okay, so what we want to be aware of with this picture is that these transverse planes of fascia hold traumatic forces. Now, the body, of course, has a self-correcting mechanism and can dissipate much of these forces. I personally, over a decade ago, had a reason or a situation where I did land on my knee, and I did fracture my patella in multiple pieces on a marble floor. And yes, I think I said ow, but the physical therapist in me was noticing what was happening as I hit the floor, and I could feel forces dissipating as it broke my knee. The actual, I think the breaking of it, there was some forces that exited out of my body. And so that's the part of us that knows how to minimize as much as possible, given the circumstances. All right, so there's one other piece we want to add in here in relationship to the dura mater. With this picture, you've already seen this part about the lining the dural tube and going into the sacrum and exiting out of the sacrum. This is an illustration from a book actually of Dr. Upledger's called Your Inner Physician in You. These are the various bones. The spaces between them are sutures. And the green here is showing you the lining of the dura mater, the dural tube, and the sacrum. Very schematic. Now, this is the part that you may possibly not be aware of. This is a schematic illustration of the spinal cord. It's only showing you two segments, but this happens at every segment, where the spinal cord gives off a spinal nerve. And then this is the dural tube here in green that is surrounding the spinal cord. And a dural sleeve exits out with the spinal nerve, and it blends with the paravertebral fascia. So you've heard that fascia is continuous, and yes, indeed, it is continuous from head to toe. And one of the direct ways that it is through that connection of the paravertebral fascia into the dural sleeve and into the dural tube. And again, there is cerebrospinal fluid circulating around the dural tube and also in the brain in that subarachnoid space. Okay, now what can happen is that restrictions can develop in the fascia, whether it's the fascia of the body or the fascia of the nervous system. And what happens is when there is a restriction, that creates tension lines that will go to other areas of the body. And the restriction has a force, okay, that is keeping it, in this case, bunched up. And then that force gets translated down through various tension lines to other parts of the body. So we could, if you wanted to have a little bit of an experiment with yourself now, if you're wearing a shirt or you've got a dress, you can, and you're seated, I presume, but you can put your hand at the bottom near your shirt and just by the where your ASISs are, just pull down towards the floor with the shirt, and you can feel something pulling on the top of your shoulder. Okay, that is basically what a tension line occurs in our bodies, and they can cause some compression. And we're going to look at some of this here in just a moment, but any part here of the body can develop a restriction, and it can translate those forces to distant areas of the body. So for example, we could have a restriction here in the intracranial membrane that would translate elsewhere. And here, this picture here of the membrane, this is relatively what we would call normal. Okay, and then here are a couple examples of what can happen to the intracranial membrane, that dura mater inside the head. You can see here in this picture, we've got basically a scar. Okay, this is that bunching up where there's not the normal pliability of fascia. And you see a whole slew of tension lines that are being exerted from this area. Okay, and this could be, and I don't know this as a fact, but this could potentially be from a concussion or some type of head injury to have this type of restriction inside the falx cerebri. Now, this is another picture of the membrane, and let's just get ourselves oriented. This is the skull, and this is going to be posterior in this direction, and then coming out at this angle is going to be anterior. So here you're seeing the falx cerebri, and here you're seeing it fold horizontally into the tentorium, and you can see that it lives up to its name. It looks a bit like a tent there suspended. But the piece that I want you to see is that there are tension lines that have caused these white areas that are openings. Okay, they have started to pull the membrane apart in these areas. And I've seen, and here it's not a hole per se, but it's very, very thin. And if it were to continue to exert those forces, it could create an opening within the falx. And I had opportunities to do mini dissections, and I've seen actual holes in the intracranial membrane from different forces. Now, what I want to just revisit with you is that what I've just shown you, those could come from a hit to the head, or because of the translation of the forces, there could be a irritation, a restriction elsewhere in the body that has worked its way up over time and translated those forces up into the dura mater, and that is contributing to those tension lines or the separation of the intracranial membrane. Okay. All right. So just to look at this again, is that you can have a restriction in the head that works its way down, translates its forces down into the body, and can create a symptom here. Or you can have a restriction here that over time, through that connection, which would be only one way, but through that dural sleeve on up into the head and affecting the membrane. And remember that membrane is forming compartments for the brain. And if it gets twisted or moved over, it can compress on the brain. And that compression can create symptoms that may be difficult for diagnosis, all right, from a traditional medical perspective. But craniosacral therapy is an osteopathic treatment, and there they are really looking for the origin of the symptomology that is being presented by any one patient. Okay, so again, this is just showing how that dural sleeve could be translating some of that. All right, so what can cause these restrictions in the fascia? I'm pretty sure you know most of them, but let's go over. First, we have misuse, all right? And so misuse is, if for an example would be lifting improperly, okay, without using your legs to assist in a lift. Overuse. So this would be a repetitive injury. If you think about your cashier at the grocery store, you know, scanning cart full of items, 40 hours a week, that could be part of that. Also disuse. So disuse would, an example would be being immobilized in a cast. And the layers of the fascia, when they are immobilized, they can get sticky. And the layers of the fascia, when they get sticky, there's an inflammatory response as well, typically from disuse. There's been an injury that involved a cast, and that can create a restriction. There are certain disease processes like scleroderma, rheumatoid arthritis that affect the fascia, and the fascia can change from that and translate restrictions to distant parts of the body. And then we have trauma, and this is referring to physical trauma and emotional trauma. So with physical trauma, this is obviously we're talking about concussion, so we would say concussion, and it can also be a slip and a fall, a motor vehicle accident, any type of physical trauma. And then from an emotional perspective, I would say that probably most of us as children at one time or another were yelled at by an authoritative person in authority, okay? And when someone is being yelled at, we like tighten up our muscles, all right, because it is a place of not feeling completely safe if we are getting yelled at. And then once it's over, you know, then we relax. But some individuals, either adult or children, may be in a situation where the yelling is a consistent and frequent behavior. And it's similar to and you may know people where when you are around them, it feels like you have to walk on eggshells. All right. And so if we're around someone most of the time where we have to walk on eggshells, we tense up because it feels like it's not safe. It's a evolutionary response, okay, is to tighten our muscles. Obviously, we're not going to start duking it out, all right, the fight part, fight or flee, but we will tighten in response to that. And of course, that is also just a reflection of stress. And stress, when we've got a lot of work on our plate, we can't finish, or it's any number of ways that we experience stress from our modern day activities will cause a stress response, which would be muscle tension, along with a lot of cortisol production, and that can change the fascia. And what we want to make sure that we're aware of, right, is that fascia can also change from positive input. And positive input is any therapy that helps the fascia to be more mobile and less restricted. And I'm sure you're familiar with myofascial release, structural integration, Rolfing. Out of Australia, there is a technique referred to as the Bowen technique. In Italy, there is the fascial manipulation technique. The Barral Institute has visceral manipulation, which is working with the organs, which are also invested in the fascia, and mobilizing the organs and or the nerves or the vasculature can also be very, very helpful. All of those are good techniques. And then, of course, what we're talking about today is craniosacral therapy. And as Donnell mentioned, it is a whole body event and therapy. Okay, so let's look at the fascia again. We've looked at the longitudinal pieces, the horizontal membranes here, and the lining inside the cranium, the formation of the intracranial membrane. And we talked about the dural sleeves as being a mode of entry up into the brain in translating forces, particularly over time. So what is a concussion? Concussion comes from the word concutere, which means to shake violently. And there are two definitions of concussion, and they're both important to know. And this is what they are described as in the literature. The first definition is a type of traumatic brain injury that is caused by a bump, blow, or a jolt to the head, or by a hit to the body that causes the head and brain to move rapidly back and forth. Okay, so here we have an illustration, particularly of the acceleration and deceleration injury. You can have a direct impact onto the brain with a bleed. The blast injury, there of course are many grades of blast injury, but there is one grade that qualifies as a concussion. The blast waves are also damaging. The mechanism is a little bit different, but the end result is very similar. So what you're seeing here is this might remind you of a whiplash injury, right? And it also includes rotational forces that are going through the brain. And depending on where the actual hit happened, you can have straight line translational motion and rotational motion. So it's a three-dimensional movement. It was once described to me probably 30 years ago that it can be kind of like a figure eight when it's doing this acceleration and deceleration. So there's three-dimensionality to it. Okay, now the second definition is a mild traumatic brain injury that changes the way a brain functions. And that looks like this. So do you love this picture? It's very intimidating. And I'm not going to teach everything that goes on here that this is showing you, but the main piece to take note of here is that what chemicals are supposed to be inside the cell are forced outside of the cell, and the other chemicals that are supposed to be outside of the cell move into the cell, and it basically creates chaos in the nervous system. Okay, so that's what happens. It's called the neurometabolic cascade of concussion. So this and this causes this to happen inside the brain. And what can then happen, you see this here is an axon, and this would be the neuron. And this is showing you what can happen structurally. Okay, so we just looked at it neurometabolically, but structurally, the axons can get twisted. Some of them can get twisted enough that they break off, and then they end up dying. There's cell death. The twisting, if you think about a washcloth that is wet and you're wringing it out, that's like a lot of pressure. If you're thinking about a wire that's trying to communicate. And so it can interfere with the communication because of this compression, in addition to that neurometabolic cascade. And then, of course, we've got the membrane here that can develop restrictions. And there are some scans that show that it actually moves over from midline. So it can change the position and the orientation of the brain within the skull. And this is showing you, of course, the cranial vault. And what I would like for you to imagine is a brain in here. And it's being moved, this is anterior, it's being moved forward and backward. And when you look at the inside of the skull, it's got some kind of jagged areas. And this particular area here is like a cliff on either side. And if you can imagine the brain being forced against that or over the top of it, okay, that can cause some damage. And I'm going to show you a magnification here of this area here for you to get another visual. So this is called the ethmoid bone here in white, and it's got this ridge that sticks up, and it's actually where the intracranial membrane attaches, or a portion of it does. And it's the part that is protruding here, where the arrow is pointing to, is like an tip of an iceberg. So the actual ethmoid bone is like the iceberg that's below the sea. And what you're seeing here is this tip. And that, when things get shoved around in there, that can be damaging. And then this area here is called the sella turcica, which is Latin for a Turkish saddle. And you can't really see, but this would be the place where one would sit if they were in a Turkish saddle. And these are the horns of the saddle that someone would be holding on to. And then this part would be where your sacrum is butted up against the back of the saddle. And inside the saddle is the pituitary gland. And on top of the pituitary gland is another structure called the hypothalamus. So the hypothalamus sends instructions to the pituitary to what hormones to produce and where to send them, okay, to what organ they are going to. And that messaging happens between a stalk between the pituitary and the hypothalamus. And can you imagine that that's part of the brain? And if it's going forward and backward, it can twist, it can turn, and have compression. And that compression could interfere with the communication that I just described for you, which is the endocrine system. And so many people with concussion have some endocrine symptoms associated with the various hormones. Okay. All right. And so what causes the brain to be shaken within the skull? Well, you guys could all create this list. And by the way, all of the verbiage is in a handout that you will receive later from Donnell. So falls are causes of concussion. And the age group where falls are a risk factor are in individuals over 65 and individuals from 0 to 5 years. Okay, fall and hit the head, that can be problematic. Motor vehicle accidents can create concussions. Sports related assaults, these would be physical or sexual assaults, and blast injuries. Okay, now if you are watching some sort of sporting activity with a child or your grandchild, or maybe there's been an accident on the street, these are the immediate symptoms of a concussion. So if you come across someone that has any of these symptoms, you want to call 911. You don't want to try and take them to the emergency room yourself. These are situations where there can be a life-threatening situation going on. When the skull hits the ground, the skull bones can be fractured, and the fractures have very jagged edges, and they can prick a artery or a vein and cause a slow leakage. And when that happens, the brain that compartment is filling up with fluid, and it's going to compress things to a degree that it becomes life-threatening. And can be a slow process, a slow bleed that is occurring. And so you really want EMS to be dealing with that, because they can measure and they have contact with ER and so on, versus trying to take someone yourself. Okay, so once again, these are the attachments of the craniosacral system. We've got the fascia of the nervous system. We have the fascia of the body, and this ends up becoming a whole body event. And what I'd like to do here is just to do a little analysis here. I see we're coming up on our time. So we'll just do one analysis. Right, so we've got 2 soccer players, and what I want you to see is that we've got their heads are colliding on the medial aspect of their cranium, but the player here on the left, the ball that has velocity and force is hitting her head at a trajectory like so. And this person here is getting more of a posterior and superior combination trajectory of a force. And you see that this shoulder is rotated backward, posteriorly on this player, and we're getting a hit into this part of her body, which would affect that thoracic inlet area. You also see that there is, their eyes are closed. There is a clenching of the teeth happening here, a stress response. And this woman here is receiving force from this player's arm that is going into her thoracic inlet. And here you see the pelvis is rotated posteriorly. The respiratory diaphragm here area is rotated posteriorly as well. Okay, so these are a whole body event. So we'll go through this just to take care of the timing. So a concussion is a whole body event. That is the takeaway. And you already have skills to deal with parts of the body. And what craniosacral therapy adds is it adds not only how to work with the body, how to the whole body, how to identify where restrictions are anywhere in the body, including the cranium. Okay, and so these are just some of the symptoms of concussion. There are emotional symptoms that you see listed here. There are cognitive symptoms, memory loss, difficulty concentrating, reading, making decisions. They might have a trouble making a decision about what time to see you when you are scheduling your appointments. And these are some of the physical symptoms of persistent concussion symptomology: sleep problems, headaches, cervical pain. I've already mentioned endocrine, balance issues, dizziness, digestive system symptoms. The effects of the concussion reach the digestive system within 6 hours of the hit. Okay, and that is not well known outside of concussion circles. So also decreased cervical range of motion, visual problems. Okay, and so how craniosacral therapy helps is it takes the pressure off of the nervous system. It improves fluid flow and exchange, and it releases the fascia of the body surrounding all the structures within the body, whether those are organs in the trunk, the muscles and bones in our extremities, or the brain. Okay, and these are some SPECT scans. You probably know Dr. Amen, but this is looking at perfusion or blood supply. And this is a patient that received one craniosacral treatment. And when you look at some of these divots here, what we're looking for is to see a decrease in the size and the depth. And so you can see how that has decreased in its size when you compare here to here. All right. And that there is a smoother look to the brain. And this is after one craniosacral session. This is showing you the metabolic activity. And this is the metabolic activity is shown here in red. And this is way too much. This is an upset brain. And after one craniosacral session, you can see the calming in the brain. Now, how does that work? Well, let's just very briefly review. We've got the dura, the arachnoid, and the pia. And we said that the pia is like shrink wrap for the brain. And here we go. Here are the pia cells. And this is all the white is going to be the cortex. Notice these glial cells. They have what are referred to as end feet, and they connect directly to the pia. So when we are doing craniosacral therapy and we're using the bone as a handle to mobilize the dura, the arachnoid and the pia gets very gently stretched, and the glial end feet also are receiving the translation of those therapeutic forces that are very gentle. And they take pressure off, like right here. You see the vasculature. That has taken pressure off of the artery. And we saw in those SPECT scans after one session that changed the perfusion. The areas were getting the cerebrospinal fluid that helps with the bringing the nutrition that the brain needs to heal and to carry out the metabolic waste, all of the gunk, so that there can be healing that takes place. And these glial cells are very popular. They're like right up there with the vagus nerve in terms of being a celebrity, is that they have many, 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 many functions. And what I just described to you is just one function where it's acting like scaffolding for the structures of the brain. And that's similar in function, certainly not in tissue, but in function to the fascia, where it's holding up and supporting all of our different parts, our bones and our organs, and so on. Okay, and then this is just a schematic. Here's a schematic showing you the scalp, the cranium, the dura, the arachnoid. Here's the subarachnoid space. There's the pia, there's the glia, and then this is the cortex into the depths of the brain. Okay. So what is a concussion? I hope we answered that for you. It is a whole body event that causes a change in the brain, in the fascia of the nervous system, and the fascia of the entire body. And so, oh goodness, boy, we really raced through that. I want you to know that all of those lists are being printed. And I want to be sure and thank Biotome for this opportunity to share with you, and specifically, of course, Donnell. She has really put together quite a resource for the massage and other healthcare providers, actually. Really impressive. And I've viewed some of them. I've seen the topics, and she was describing what she's working on with diabetes. It's just so thorough for being in such a short amount of time. And then, of course, I also want to thank Jackie. So Jackie's in the background somewhere there, and Jackie is works as part of our administrative team. And I just want you to know that Jackie is not a therapist, but she has changed the lives of people by her persistence. Her persistence actually directly resulted in someone receiving craniosacral therapy and tested normal after being previously tested on the autistic spectrum. So she's like Wonder Woman. So thank you both, Donnell and Jackie, and thank you all for your very kind attention.
Well, thank you, Mariann. That was amazing. And the graphics were incredible as well. Before we sign off, there's still time to do a chat or comments for Mariann to answer. But Larry has asked, how long after a car accident can craniosacral be done?
Well, the main thing, Larry, is to be concerned about a potential slow bleed. And actually, Jean-Pierre Barral, who developed visceral manipulation, he does not, and this is an osteopathic technique, he does not like to treat anyone until about 3 weeks after any injury, because he wants to see what the self-correcting mechanism will do. And I apply that with my craniosacral. I've studied visceral manipulation as well, but I apply that from a craniosacral perspective because the body does have an inherent ability to heal. And it is busy after a concussion trying to rearrange everything. And sometimes the doing craniosacral therapy in those initial stages is can be too much. And so I personally like to wait about 3 weeks.
All right, Mariann, there are 2 other questions that have come in. If someone has a tremor issue, will this, being craniosacral therapy, help?
So is the tremor issue related to the concussion, or is this a other, just a question
It was
about
just a
something?
question without further explanation. It just, if
Mhm.
someone has a tremor issue, will craniosacral therapy help?
Well, that's a little bit difficult to answer without context, because there are many things that can cause a tremor issue. Okay, there can be Parkinson's, there can be an intention tremor, there can be resting tremor. These are all different types of tremors that occur. And in some instances, we do have a therapist that has done some work with Parkinson tremor. But I don't want to, and the work that he's done has been helpful. I'm not sure that it has completely taken them away. So I would never say ever to someone, oh, I can help you with your tremors. Craniosacral therapy can take care of that. I would not suggest that. Mhm.
Okay, thank you. And Barbara is asking, do you recommend incorporating craniosacral with other therapies, or should it be done as a standalone treatment?
Oh, Barbara, that's a great question. Thank you so much for asking it. Dr. Upledger loved integrating craniosacral therapy with all kinds of other therapies. He's the one that invited Jean-Pierre Barral to bring his work to the United States. He worked with acupuncturists. He even had, he was just hilarious sometimes. He had a cellist come in, and he found that certain chords from the cello facilitated a release. He worked with myofascial release, acupuncture. He was responsible. Jackie, what is the therapy with the bone? It's escaping me right now. We usually see them at the convention. He brought
the structural folks.
No, I'm sorry. I should have probably not said it if I can't remember the name of it. I'm having a little thing right now. But the point is that he was very, very inclusive of all types of therapies. Absolutely. And he had a psychotherapist on staff, and people from many different backgrounds. He himself, as an osteopath, did manipulation. His wife was a chiropractor, and he would be working with the craniosacral system. And then I would see him go, oh, here. And he would do a manipulation, and then he would ease right back into the craniosacral therapy. So he would never encourage you to give up what you have in your toolbox. It's just a matter of playing with the order and how much you want to do of it, and how much of the craniosacral therapy. You get to discover that with your patients.
Larry has another question, and I'm not sure if I'm translating it correctly, but how long post-concussion, and then it says MTS, years can a person still benefit from craniosacral work?
Yeah, I think Larry, what he might mean is it months? Is it years? How long after can
I see. Yeah.
person still benefit from craniosacral therapy post-concussion?
Well, okay. Thank you for the translation. Okay, so I'm going to answer like Dr. Upledger, and then I'm going to give you a little bit more. Okay, he would just say it never hurts to try. Okay, people ask him, well, will it help this? Will it help that? He say it never hurts to try. And what I found is that people can have like a headache for 30 years and get craniosacral therapy, and their headache can disappear. Does everyone's headache after 30 years disappear? No. Okay. But I have seen very strange things occur. And I remember I had a patient come in and she said, oh, you know, the doctor says I can't have any more children. I don't have the fertility now, or whatever it was. And I said, well, that's his opinion. And then we found some restrictions in that pelvic diaphragm. Those were worked with. And then she, I happened to see her, actually, it was at church. She came up to me and said, here's the baby that you helped me have. Okay. Because there were some restrictions in the pelvis that were causing some type of compression, and everything was operational. It just needed to be decompressed. And again, I would never say to someone, oh, I can help you, baby. I don't ever say things like that. I just say it can be helpful in some cases. It's worth a try.
And again, I think Larry might be asking about the duration of treatment. I mean, will post-concussion, can those people still benefit
Yes.
months and years?
Yes, absolutely. Because they've had those symptoms, and they may, like the stomach issues, people don't attribute to concussion. And that can be something longstanding that can be helped as well. So yes, the answer to Larry's question is yes, you can benefit many months, years later. Okay, people typically feel lighter after. I've had children with concussions, and then they walk out and they don't really have the verbiage, but they'll say, my head, it feels lighter somehow, because some of that compression is off the structures.
Okay, well, thank you for answering these questions. We have minutes left. So Mariann, I will just jump in and say, I know you'll be at AMTA National in Phoenix, the end of August with a class, and people can learn more about that on AMTA website.
And if they come to that national AMTA, Jackie, she's got already all set up with a treatment table, and we'll be doing some demonstrations at the booth. And, you know, one time a table was sent that was not, it was missing a bolt, and boy, she was at the hardware store shopping for a bolt to make sure that we did those demos. So if you're there, be sure to stop by the booth and we'll give you a little session, you know, a little mini session.
Sounds great. And Jackie, why don't you quickly say what you'd like to say from Upledger Institute?
Okay, thank you. Well, first of all, I want to thank you, Donnell and Mariann, once again. Outstanding job. And everybody is still on, and I'll wind it up quickly because I'm sure you all want to get to dinner or whatever your evening plans are. But we will be sending, there will be a follow-up letter that will be coming from me for those of you who attended, with another handout that Mariann may have mentioned, which is a research study, a recap of this session, and also a special offer from us because she touched on craniosacral therapy. She teaches a class that she developed related to concussions. The foundation for that class is taking your entry-level classes and another one or two upper level courses before you're ready to do that. So we want you to have a special offer to take advantage of the entry-level classes. That'll be coming from us in the next day or two. Mariann also mentioned that she'll be at AMTA National, as will we. If you have any questions for us in the future, you can always send those to info@upledger.com, or you can go to the website, which is upledger.com, and you'll see in the contact us section, the same information. We also, as Donnell has referred, you know, we're all about awareness and getting education out there. Upledger also offers some varying topics of free workshops, anywhere from 1 to 3 hours. Those are also available on the Upledger website. So I want to thank you again, Mariann, for your time and this wonderful presentation and all the kind things you said about me. We make a good team. Donnell, of course, I've worked with for years. And thank you all very much for participating this evening. And I'll hand it back to you, Donnell. Thank you.
Okay, in closing, and thank you both for this evening's Edutalk. Everyone, thank you so much for attending. Please watch your inbox tomorrow for the follow-up email with the recording of tonight's Edutalk, with contact information again for Upledger Institute and AHI, the International Association of Healthcare Educators. It will also have the handout, and we'll mention as well the upcoming Edutalks. We've got oh, wait, I can't go on another minute without saying Edutalks is celebrating 3 years of presenting
Good job, Donnell.
expert talks, and it's exciting. We're looking forward to a great rest of the year and 2024. And with that said, August 8th, we have Irene Diamond presenting Maximize Earnings, Minimize Hours, Embrace Outcome-Based Pricing. August 15th, as we mentioned, there is a new Edutalk Diabetes series, which, please listen in. It will be with Linda Lockett-Brown, and she's presenting meal planning for diabetes, more than carbs. And August 22nd, August 22nd, we have Dr. Tiffany Ryan presenting new and innovative restorative touch approaches to body work. And we hope to see you all there. Thank you so much for your interest, support, and participation with Edutalks. And visit the Biotone website under the Edutalk tab to see our 3 years of Edutalk recordings. Thank you so much, everyone. Be safe and join us again. Take care.
Thanks, everyone.
Thank
Bye.
you.
Thank you.
Thank you. Bye.
Bye-bye.